and we will talk about the financial well-being of a shock center and a shock team approach. So we heard a lot the last couple of days about the complexity of the shock care, and I think that we can agree that this is a complex syndrome, and on top of the elements of the complexity that you see listed there, you can add additional layers of complexity and variability like the age, the comorbidities. I don't know in your situation in Utah, we never have psychosocial situations with our patients, and the exit strategy is always straightforward, as you know. So this adds additional layers of complexity when we deal with this complex syndrome. And as you know, the idea of having teams and a team approach dealing with it was discussed for many years. Now we are in a decade into the first shock teams. This is a collaborative publication that just came out for the centennial edition of the Journal of the American American Heart Association that I had the honor to participate, and it was put together by Dr. Senman and Katz. And in this collaborative publication, they reviewed the outcomes and what we learned from the first shock teams around the country and the world. These are the first 3 shock teams that they announced their results at Inova, University of Utah, and Ottawa. And you can see that these were not randomized studies, but they showed the benefit that you see when you employ shock teams. And then in addition to these, in this paper, they also reviewed the results, we reviewed the results of another paper from larger number of patients, many hundreds, in this case 546 versus 696 from the three critical care cardiology network. And the outcome there also suggested that there is improved survival when you employ a shock team, with some differences in how you employ devices and swan guns, catheters, and others. So in this collaborative work, we also reviewed the things that we learned and the things that we need to do in order to move the field forward. And one of the things that came out as a consensus is that for most of the shock teams, we have all these specialties involved that you see there: heart failure cardiology, critical care, CT surgery, interventional cardiology, and additional elements to supplement the multidisciplinary nature of these teams, as you can see in this illustration. And so, in the first day of the meeting, our administrators, represented on the panel by Ms. Fisher, I don't know if she's in the room still, brought up, as we all bring up all the time, how about the cost when you have these centers and these teams? How many experts should bill for this one patient? And of course, I used to have a mentor that we all admire because we call him the triumph of common sense. And then Ms. Fisher said too many cooks, potential disagreements, delays, and she made a common sense argument, a question essentially, right? She posed it. Would it be more cost effective if we have one well-trained physician to take care of these patients? And because common sense can have counter-arguments, the counter-argument in the room and in our minds is, well, if the team indeed functions well and leads to better outcomes, maybe this is more cost-effective. So that's why we put together this work to answer these questions. And what we did is we went to our hospital and we asked them to open their books. They don't like that. So we had to negotiate, and they go like, and then you will publish this to everybody? Yeah, of course, that's what we want to do. So it took some time, it took some negotiation, it took some talking, and we got it done. And I'm going to walk you through, because as you know, we're not financial experts, and if you have tough questions for me for the methodologies that I'm going to walk you through now, please we can discuss later and call my financial experts that they helped us. But I'm just going to try and walk you through on what we did in order to approach this. The comparison groups were the same comparison groups in our circulation paper of the first shock team that was published from our group, which showed the outcomes between 123 people that we treated with the shock team with the 121 people right before we had developed the shock. It's not randomized, but it's the best we could do. And the cost and outcomes were calculated for a time horizon of 1 year. We utilized individual medical care services, hospital charges, obtained from the hospital charge master file. This is where the negotiations were happening. And we included all care-related charges associated with care in the ICU, in the floor, temp and durable MCS devices, operating room, and organ transplants. So the primary outcome of interest, this is where the terms will come in that we're not so used to it, and so I'm going to go slow, was the incremental cost effectiveness ratio that our financial analysis people taught me is defined as the ratio of the incremental cost between the two treatment strategies, in this case shock team versus standard of care, over their incremental difference in the outcome, the effectiveness. The cost was defined as the cost difference between patients treated with the shock team compared with control at the individual level, and similarly, incremental effectiveness was defined as differences in survival probabilities and quality-adjusted life years. Other outcomes of interest were the survival at discharge at 1 year and the quality of life at 1 year. Now, these are some of the baseline characteristics that we've already published that even earlier when we published our first experience, typical things that you would expect in cardiogenic shock patients. You see the etiology there, really sick people. You can see high percentage of CPR and mechanical ventilation. If anything, the shock team had a little bit sicker patients, and you can see there the lactate and the pH. We're talking about sick people. And again, if anything, the shock team tended to be a little bit sicker. These are some of the outcomes. And you can find details in the publication, but you can see that the shock team did better, and you can see also the absolute numbers of the cost there. Now, what really influences in this analysis the outcome is the combination of the cost and the effectiveness. So I'm going to walk you through this famous incremental cost effectiveness plane now, which is the meat of the results. So it summarizes, you see all these dots there, and you're wondering what's going on here. These are patient scenarios. It's called probabilistic sensitivity analysis, aiming to show parameter uncertainty, because this will change from one scenario to the other, right? And their impact on the cost effectiveness outcomes. And then the point coordinates on the two axes present combinations of differences between shock team and standard of care patients in terms of the effectiveness in the quality adjusted life years and the incremental cost. Now, the points in the lower right quadrant with green indicate scenarios where the shock team is cost effective and dominant, better outcomes at lower cost. And on the upper right quadrant with red indicates scenarios where the shock team approach achieve better outcomes, but at a higher cost. So based on currently accepted US standard cost effectiveness thresholds, this is where what we discussed earlier, it becomes in the political decisions and what is going to be this accepted. But by what we're using right now in our country, the points below the willingness to pay threshold per quality adjusted life year indicated scenarios where the shock team approach was more cost effective, which was the majority of these probabilistic scenarios. And suggesting that this is a cost effective approach by what we know and what we employ as thresholds right now in our country. Now, this is a little bit more complicated when you talk about places like us, that we serve many states around us, and then you get patients coming, as you see there, from more than 20% of the geographical area of the country. And this is just a paper we just published suggesting that there are additional elements that we need to employ now as we expand our financial analysis to include this additional element of cost effectiveness, right? And one of the things that came out when we looked at the predictors of the native heart survival, you can see there that the shorter onset to MCS deployment was one of the predictors, which speaks to what we heard earlier from other speakers as well about the need of virtual collaborative shock teams, and then additional layers of cost effectiveness, where it will include cost from other hospitals, transfers, and other things as well. And I'm glad that Dr. Yo is going to give a talk later, who is one of our collaborators that we work together on these issues. Now, in this paper I shared with you earlier, you can see a bit more about other elements that we need to discuss. And as you can see there on the top, the financial is always of interest. And I want to bring to your attention, and there's a paper going to come out, our think tank that was just done a few months ago in DC, organized again by Dr. Senman and Katz, where you can see several of the items that were discussed, and there's going to be another one coming up this fall. And of course, one of them was the cost effectiveness and the financial well-being of our shock teams and our shock centers. And when it comes to well-being, we need to talk also about the fun and the well-being of the team. And we every year do a fun picture. We have one of our coordinators, Jonathan, to make sure we get this picture done every year. And we get a serious picture as well. With this, I'd like to thank you and open it to questions.
Stavros, I think that was a fascinating study, and the key is, of course, how do you define standard of care? Because you've got this big team, and you're saying this is amazing, and then you've got standard of care, and those are the guys that you're trying to beat out, right? And then the second thing is, I get cost, but what about revenue? When you have a big team, how do you get reimbursed for everybody? So you could end up with a lot of cost that you can't necessarily get reimbursed for, so in the end, the institution loses. Could you address that?
Yeah, no, that's a great point. And as long as we get the reimbursements, and so far we didn't hear any complaints from the hospital about not getting that done, then everybody's happy. But you are absolutely right. And the current climate in the country suggests that what you just asked may become a critical issue as things are coming down to cut the reimbursements, right? Starting from the Medicare and the programs that I'm hearing that they will have changes. And this is where this kind of studies and analysis from the hospitals that they get reimbursements right now for everybody is important, not just from us, from all of you guys. So when the Dodge comes to say, why do we need that? Then you need to show studies like that so they can keep reimbursing the teams. Otherwise, they will tell you in the common sense argument we started, we just need one. Why do we need a team? And is it cost effective? So these studies and this analysis are not enough to be done only in one hospital, right? And with 250 people. It needs to be done by all of us, getting prepared for what you said, because it's going to get to that point.
You know, that's a very important point, because it's a very complex world, and cardiology and CV surgery has been bundled up in many procedures, but heart failure is not, the cardiogenic shock is not. And you can see when you know, I have done a couple of courses for coding and stuff, and physicians can bill differently. Like cardiology, in a patient that has a mechanical circulatory support, cardiology, surgeon, critical care, all can bill. The patient goes a higher DRG, and the hospital get more revenue for that patient, and it's not bundled. That patient, they pay daily for that patient, for daily patient management, for durable LVAD or temporary circulatory support. So the hospital has to understand all this, because really, and at the end, they get a big bonus. I give you the historically example when COVID, every patient that they use the code for COVID, there was a big revenue that was paid to the hospital. So, I mean, if you add the revenue part, it will be an amazing story, I believe.
Ray, we are a little bit out of time, so make it quick, Ray.
Stavros, excellent on the financial analysis, but any hospital administrator, if you go through one single shock patient, the DRG1 and Pella or whatever LVAD, it's actually lucrative. And if you look at, they know the numbers. It's a marginal profit for them actually. When you compare it to TAVR programs and other programs, it's actually financially well.
Yes, that's a great point. Well, we need to wrap it up, and we may be able to discuss later during the other talks. I would like to invite my good friend and colleague, Dr. Phyllis Bilia, to give the next talk on navigating the emotional well-being of shock providers and shock survivors.